everyone. Welcome to Grand Round. Brief announcement. Today is officially the beginning of the MOC program for attending, so please sign up. You get 1 point today towards 10 points by the end of the calendar year. Please contact Janie Wood. It's online, or there are forms in the back of the room if you need to sign up. Today's speaker is Dr. William Wellborn from the Department of Physical Medicine and Rehab here at Carilion. He's a trained psychologist with extensive training in rehab counseling psychology, behavioral medicine, environmental and therapeutic psychology, and a fellowship in clinical neuropsychology. He provides services as an outpatient for patients 16 to 99, currently, not 100. And evaluation and diagnostic services with the Traumatic Brain Injury Program. In 2011, he developed and launched the Carilion Sports Concussion Program that provides a multidisciplinary approach to the management of concussion, 6 years and up, with an emphasis in sports concussion. 2011, he became an impact consultant. Please welcome Dr. William Wellborn.
Well, y'all hear me? I mean, it sounds pretty good to me. Anyway, just to a little aside from what she just said, I don't really see people from 6 to 10 years old. That population, it's okay. I mean, I think it's helpful for them to know that I really started about 10 or 11 years old and up. Anyway, with that, the talk today came about when Janie contacted me, and I asked her, what did she want me to talk about? And she said several folks wanted me to talk about return to play guidelines after a concussion. And I said, what else do you want me to talk about? And she said, well, pretty much anything you want to. And so I said to myself, I'm thinking, okay, the return to learn guidelines sort of go hand in hand with return to play. Also, in the past 4 years, there has been 6 clinical profiles that came out of the University of Pittsburgh Medical Center that I think is very important in looking at the fact that the group of head injury is not a homogeneous population, where probably 6, 7 years ago I was treating them everybody the same, or pretty much. So it's a heterogeneous population. And that's why I'm going to go over the clinical profiles. This is something that I myself have recently trying to learn more about in detail. I've known about them since 2014 when they came out. This year, Mickey Collins and Anthony Contos wrote a book about concussion, and it's pretty much described in great detail there. So I wanted to go over that because it does help when you come to a difficult patient, athlete, that maybe is not getting well as quick as we would like. So it is helpful to look at potential profiles that they might fall into. And then last is CTE, or chronic traumatic encephalopathy. And I thought, well, if I'm asked this question 2 or 3 times a year, you all might be asked the question 1 time a year by some parent that has gone to the internet and looked it up and said, well, is my son or daughter going to get CTE? Well, anyway, I'll talk more about it, but the answer is no. But anyway, we'll talk about that later. I don't have any affiliations with anybody. I don't have any disclosures to tell you about with anybody, any manufacturers or anybody that I'm talking about here on the screen. So talking about what is a concussion, every 4 years there is a conference that is an international conference on sports concussion. In 2016 was the last one, and it was in Berlin. And anyway, they come up every year and they change or they tweak their definition of a concussion. And so anyway, out of this conference this year, it's a brain injury that is induced by biomechanical forces. We all know that. It's either caused by a direct blow to the head, face, neck, and the energy is transmitted to the head. Typically, it's a rapid onset of short-lived impairment in neurological functioning. The symptoms largely reflect functional disturbance, and seldom is there any evidence on imaging that says that there's a problem. Clinical signs and symptoms typically do not involve loss of consciousness. Resolution is typically 14 to 21 days, and it does follow a sequential course. And a lot of times the patients and the athletes that I end up seeing are the ones that have symptoms that may be prolonged. I'm probably going to spend a little bit of time on this because when you folks send me a patient, I know I send you the reports. But basically, it's a 2-hour evaluation the first time I see an athlete or student. And the patient comes in typically 30 minutes before they see me, and they do the impact test, which is a computerized neuropsychological test. And with the average patient, it can be done in about 30 minutes. If somebody has a learning disability or ADD or ADHD, it may take longer. If they're really, really impaired, I've had people take 45 minutes to do. But anyway, it's data that measures verbal memory, visual motor speed, and reaction time. Also, after that, then I meet with the parents and the student athlete, and I do a clinical interview. In the clinical interview, it's pretty comprehensive, and a lot of what you see on the screen is part of it. But I do want to know how they got hurt, how many times they've had a concussion. I want to know the mechanism of injury. It could be at football practice. It could be soccer. It could be where two people come together and they hit each other like that and the head's thrown back. And it's sort of like a whiplash injury. It could be somebody just falling on the ground and hitting their head and their head bounces. I mean, there's all kinds of mechanisms of injury. And some of the patients that you folks send me, I mean, sometimes it's not even sports related. But getting a good history, understanding their academic history to some degree, what kind of grades do they have? Do they have a history of ADD, ADHD, learning disability? What are their grades like in school? I mean, sometimes you have somebody comes in, they say, I make B's, C's, D's, and F's. And then you say, what do you make the most of? And it helps you figure out, well, where should they be when you're trying to figure out how they score percentile-wise on the impact test. Also talk to them and ask about potential risk factors. And up until recently, I asked them, do they have a history of headaches? Do they have a history of migraine headaches? Do they have a history of meningitis or infections to the brain, learning disability, and ADHD? Later in the presentation today, you're going to see risk factors for the clinical profiles, and with that, there's some added ones that I'm beginning to ask people about now. Do they have a previous history of a neck injury, neck surgery? Do they have history of migraine headaches and family history of migraines? Do they get motion sickness when they're in the car? Any problems with that as they've progressed in their early periods of life? Then the one thing that I do towards the end of the interview is try to, explain to the parents that, their son or their daughter is going to get better. And more often than not, sometimes the parents have brought the child to the emergency room. When they come to the emergency room, at that particular point in time, I mean, everybody's pretty devastated about what they're looking at. So they are kind of relieved when I can tell them they're going to get better. And I tell them how we're going to do it. The other thing that I'm going to do up here, I'm going to ask Alex to come up here. And I'm going to use him as a patient right now. Yeah, now, come on, let's go. I want to get this over with. I'm not used to doing this, guys. All right, I'm going to ask him to sit right here. And before he comes up here, or the patient, I ask them to have a problem with their neck. The shoulder is here, you know. It's connected to the neck, and the neck's connected to the head. So I always ask everybody, you know, do they have a problem with neck pain? Sometimes they say yes, sometimes no. If they say yes, then I want to know, is it constant neck pain? Is it intermittent? Then I'll briefly just say, okay, on a scale from 1 to 10, with 10 being as high as it can be, where is it? You know, 10 being so bad you need to be in the emergency room, 5 is in the middle, and 1 is, you notice it. So anyway, I get that information, and that goes into my evaluation. The other thing is, I want to do these, what you're going to see right now, and I debated whether to have him face me, me look at you. No, but I want to briefly show you what I do, because you'll see this in my evaluations, and it's real quick. The thing about it is that part of what I'm going to do is part of VOMS, which is Vestibular Ocular Motor Screening. It was developed in 2014 by a woman at the University of Pittsburgh, and her last name is Mucha. Anyway, to do what she asked you to do, it takes about 7 to 10 minutes. What I'm going to do here, I know I'm running my mouth, but it takes less time than that. So the first thing I do is I want to know, does the patient or athlete have problems with balance? Now, what I'm going to do is just very simple. Okay, stand up. Now, most people aren't as tall as him. Well, y'all know what I mean. So anyway, what I say is to the child or the athlete, okay, I want you to hold my hands, or just I want them to know that I'm right here. And I'm not going to let them fall with what I'm going to ask them to do. So I say, okay, what I want you to do right now is look straight ahead, all right, and I want you to stand on your right foot. Well, he can do it. Okay, stand on your left foot, and he can do that too, thank goodness. All right. And then now I want you to look straight ahead, all right, and I want you to close your eyes. I'm right here, and I'm not going to let anything happen. I want you to stand on your right foot. Then if there's wobbling or sway, hey, we got a problem. And then you do it on your left foot. And he can do it, so now he can sit down. Okay, so with that, that's how I evaluate balance. It's pretty simple. There's other more sophisticated ways of evaluating balance, but hey, with all the information I'm getting, I don't need to go much further. Okay, so now what I want to do is I want to test for a vestibular problem involving movement. So what I do is I ask the athlete patient to put their thumb and arm out straight like this. And then what I'm asking them to do is I want you to take your thumb in your hand, pretend like I'm at 12 o'clock, and I want you to move your thumb in your hand to like 10 o'clock, then to 2 o'clock. Now what I want you to do is I want you to go back and forth between 10 and 2 with your hand. I want you to follow it with your head and your eyes and turn your neck and follow it and go with it. Now go faster. Faster. Come on, you're young, you can do it. Okay, stop. Now look at me. Do you have a problem with dizziness or headache? Okay. Anyway, that just helps me evaluate for a vestibular problem with movement. Then the next thing I do is I want them to look me straight in the eye. I'm going to show them what I want to do. I want them to go back and forth, keep looking straight, but go back and forth from finger to finger. Don't move your head, just back and forth from eye to eye. Go faster. Okay, you got a problem with dizziness or headache? Okay. When you're doing this, let me tell you, you can get all kinds of weird answers. They can say, oh, I got swimming headed. Well, what does that mean? Anyway, I'm trying to get them to help me understand about dizziness. I mean, I've heard everything. Y'all have too. So anyway, then I get them to go up and down. Same thing. Dizziness, headache. So what I'm testing it for now is I'm testing for vertical and horizontal gaze, which is part of the vestibular system. And the last thing I want to do is I'm going to say to them, okay, one time I did this. Anyway, the patient that was sitting here, I mean, I use this term loosely, but anyway, they freaked out. I think I scared them. So now every time before I do it, I say, okay, you see this stick I got? I'm not going to beat you with it, but I am going to take it from right here and move it towards your eyes, okay? And as I move it towards your eyes, then what I want you to do is look at that white dot. And if you see that white dot, right now it's how many? Okay. So I say, I want you to look at it, and if that white dot turns into 2, you see two of them or it separates, tell me when it happens, and I want you to do that by saying the word now. And so I just go like this. Okay, you're good. What happens, correctly is you should not have any problems if it's greater than 5 centimeters from their nose when they say the word now, then they got a problem with convergence insufficiency, and that's worth noting. A lot of times you'll see problems with vestibular and ocular going together simultaneously. I mean, not simultaneously, but part of the evaluation. Okay, you're good to go. No. Pardon me?
White dot somewhere on the bigger one.
Yeah, there's dots with red, white, and green. White. Well, you can go up here and look at it later. I mean, I'll show it to you. Also, when they come in, I ask them to do the symptom checklist from the sports concussion assessment tool. It's 22 symptoms. They rate them 0 to 6. And then I ask them to do the dizziness handicap inventory. And with that, that's a way of evaluating for dizziness. And they essentially, on that instrument, they just answer it never, sometimes, and always if they have a problem. The reason I put CT and MRI part of the evaluation, no, I don't order MRIs or CT scans. Sometimes they come with them or they're in the history from the emergency room. It is worth noting. There was a physician that called me 2 days ago from down in Southwest Virginia and asked me, what do I do with somebody that's 16 years old and they had hemorrhages, very, very small, in the brain. It's less than a month, but it's very, very rare. I mean, to me, that person had more than just a simple concussion, and that's for another story, but you do have positive findings on MRI and CT scans sometimes. So with that, that sort of covers the evaluation. Almost everybody that I see, I usually see within, most of the time, within a week of them having a concussion, so it's rather acute. And so after I do this, then I tell them I want them to do cognitive and physical rest. I tell them that I want them to particularly stay away from screens, not using their phone. I tell them not to play any video games, not use a computer. And this is really short-lived, I mean, only for about a week. And then I talk to them about physical rest and not engaging in sports-like activities or a lot of activity. And then I just say, but I do want you to walk every day. Then there's another group of things that I call healthy behaviors. In Mickey Collins' book and Dr. Cantos's book, it's behavior modification, but they talk about sleep. And I can't tell you, folks, how important sleep is as you go from the beginning to the end in treating these people. I saw somebody on Monday, they're averaging 3 hours of sleep per night. Well, most of y'all in here either are or have been a resident, so yeah, maybe that's normal for you, but it's not normal for the rest of us. So if you only get 3 hours of sleep, how are you going to feel? I mean, it's not going to be good. And if you look at sleep and you look at the symptoms on the SCAT-5, sometimes you don't know whether that's sleep-related or whether it's just concussion-related. So I can't emphasize how important sleep is, so I talk to them about getting 8 hours of sleep. I talk to them about getting in a habit of going to bed at a certain time, getting up at a certain time. I also tell them that if they're not used to it, I want them to eat 3 meals a day. They don't have to get, a meal like you get at Country Cooking or whatever, but if they're not used to eating something, eat something every morning, for example, like a small container of yogurt, protein bar or something. I want them to eat and have snacks between meals, but healthy snacks. I usually tell them no chips, no candy bars, because I want their blood sugar level to remain as stable as possible. I want them to drink a lot of water. Over time, I've found that some athletes come in with headaches. They've been to physical therapy. They're not getting better. A physical therapist called me one time a long, long time ago and said, I think they're dehydrated. They came to see me, and I told them I want them to drink a lot of water. Come back in a week. I said, drink a lot of water. And when your feet hit the ground in the morning, start drinking water. anyway, they came back and the headaches were gone. So hydration is very, very important. Stress management, even in children and adolescents, is important. And then with that, talk about exercise, mainly walking. I probably spent too much time in doing this, but I felt like it was necessary. As I mentioned earlier, there's trajectories or profiles. Initially, they came out from Pittsburgh as calling them trajectories. Now they're calling them profiles. And this is born out of the research up in Pittsburgh where they have worked and decided that the head injury population is more heterogeneous and not homogeneous. And because of that, it does help guide in developing an individualized plan of care. A lot of times, I mean, the people that are involved with me and the people that are resources to me in helping get people better, we're not in one location. But a lot of times it does take various specialties to help with this process. There's several physical therapists in town that I use pretty religiously, as some of you already know, who have between them probably over 20 years experience in dealing with neurological problems. They're very good at doing vestibular therapy, so I use those folks. There are several occupational therapists. There's one particularly in the New River Valley that is very, very good at doing vision therapy and dealing with visual ocular problems. Also, I have found it very difficult here in Roanoke to find a neuro-optometrist that really knows how to deal with vision problems from a concussion very well. There's a neuro-optometrist that is in Charlottesville who now has moved to Waynesboro that has probably 15, 20 years experience. There's one gentleman in the Blacksburg, Christiansburg area. As I understand it from talking to the doctor at Waynesboro now, that she has trained 2 optometrists. So she says, don't call them yet, Bill. They're not ready. But she's going to be supervising them and helping them in the Blacksburg, Christiansburg area in dealing with visual problems from a concussion. So anyway, the group out of Pittsburgh came up with these 6 profiles: cognitive fatigue, vestibular, ocular motor, post-traumatic migraine, cervical, and anxiety and mood. And because there's a question later on, I'm just going to tell you this. One of the probably least recognized, I think, that we all sometimes overlook is the cervical, and the importance of looking at cervical problems, neck problems, and how it's connected to the head and can cause headaches. But anyway, the profiles, I'm going to go through these. Well, first I'm going to talk about the risk factors. Risk factors with regards to age. Younger people in general are slower to recover than older folks, even compared to adolescents. High school, there's a study by Field in 2003 where high school athletes are more impaired with cognitive deficits than a larger group of college athletes. There's another study that said high school athletes performed worse on memory and balance testing than college in the first few days after injury. Another study, adolescents are at greater risk for poor outcomes than college-age adolescents. And then recently there's been some studies that are challenging what I just said about younger people having a more difficult time. With regards to whether you're male or female, it's long been suggested that females are more at risk for concussion. Females in same sports as males are more likely to have a concussion. There's several studies that suggest females have worse outcomes than males. At the University of Pittsburgh in 2012, females report more symptoms and perform worse on memory tests than males. Females, in another study at Pittsburgh, females to have more overall symptoms of dizziness and vestibular ocular problems in the first 4 weeks after a concussion. And if you look at concussion history, the research here is really kind of mixed. There, for a while, was studies that said if you have a history of 1 to 2 concussions, you're more at risk for having additional injuries. More recently, the researchers have said that, If a person has sustained 3 or more concussions, it puts them more at risk. Some of you folks in here probably have heard the notion of 3 concussions, strike, you're out for good. That is thought or was named the Quigley Rule. Then in 2017, Curry compared patients with initial and recurrent concussion and found that they did not differ with regards to outcomes. And from that study, it raised the issue, were the concussions treated appropriately from the first time to the second time and maybe even to the third time. So these are some of the more risk factors that have been talked about for a long time and are fairly well established. These other risk factors that I'm going to put up here right now is, does the person have a history of ADD, ADHD, learning disability, history of migraines, motion sickness both individually and in the family, anxiety, sleep problems, history of vision problems, neck pain, neck injury, neck surgery. And the last one I put up there because it's come to my attention over time, and I put it up there, you know, if you've got a student or an athlete that is in 3 or more advanced placement classes and they're making straight A's, but they've had a concussion, what is that going to tell you about that person? It's probably going to tell you, hopefully, that it tells you that they're obsessive compulsive, they're very driven, and more often than not, these types of individuals have problems with anxiety and mood because they're so devastated that their life has been disrupted. So anyway, those are some of the more emerging risk factors. What I have begun, and I'm slowly doing this because it's not in my template, but I am asking more about motion sickness. I'm asking more about, do they have a history of vision problems, where I didn't necessarily do that before. So in looking at the cognitive fatigue profile, the risk factors for it down at the bottom you can see is ADD, ADHD, learning disability. They've not modified their school or academic or work schedule, and a lot of times these folks have played through their injury. This to me is probably maybe the more common of the profiles and probably in some ways the least complex. The symptoms are fatigue, decreased energy, nonspecific headache, sleep disruptions. As the day progresses in the academic setting, things get worse, the symptoms increase. They don't do as well in the academic setting and their schoolwork. Treatment for this is reducing the demands. Going back to the healthy behaviors that I talked about earlier is regulating sleep, helping them with diet, hydration, and stress. Sometimes psychostimulants and medications for sleep for people that have prolonged symptoms can help with this. Another thing that's really helpful in an accommodation is giving them breaks throughout the day where, you know, maybe in the morning the breaks might be shorter than the breaks might need to be in the afternoon. But anyway, this is the cognitive fatigue profile. The vestibular profile, that's what I was really testing for up here to see if the person had difficulties with vestibular problems or visual ocular problems. The risk factor for this is motion sickness, history of migraines, and having dizziness at the time of the injury, and also having dizziness when they come in and see me, and their dizziness handicap score is quite elevated. On this one, symptoms are dizziness, vertigo, fogginess, problems with moving your head to the side, moving it up and down. There's a lot of anxiety and overstimulation in complex environments. And the treatment for this is vestibular therapy, in addition to cognitive and physical rest and modifying the activities that they involve where they're going to have difficulties with their vestibular system. One of the treatments that I have become more aware of is what's called dynamic physical exertion, and this needs to happen in physical therapy more towards the end of therapy, physical therapy. If we think about exertion therapy, we typically think about it as being having the person reach an aerobic level, they're doing it in a static kind of way. It's not dynamic. We monitor their heart rate. A lot of times it's thought to be stationary, person riding a stationary bike, cycling, or being on a treadmill. But if you think about it, most sports and daily activities, it's not just being stationary. There is a lot of dynamic movements. There's lateral movements, vertical movements, and then there's the integration of visual input, proprioceptive awareness, and navigation, particularly when you're engaged in a physical activity in sport. So if you think about it, if a hockey player might do very well in the static kind of environment on the treadmill, stationary bike, then all of a sudden if you start introducing lateral movements, they may have problems. And as I'm reading and I'm learning about this, what I was thinking about was that I've evaluated 1 or 2 college students in the last year, and they were not able to get back to sport in a successful way. And the type of physical therapy that they were doing, there was not any dynamic exertion part of the protocol. And this whole notion came into play in the past 2 weeks of preparing for this talk. So I think it's important, and there is the physical therapists that I work with, I do know that they do some of this, but I want to talk to them about doing it some more. So anyway, that's the vestibular profile. Ocular motor, risk factors, a history of vision problems. They typically have blurred vision, they have headache, eye pain, difficulty in visually based activities. They may have trouble with screens and TV. They may have slowed reaction time, decreased visual memory, and when they want to test, like I tested Alex, they should have problems with convergence insufficiency. In our area right here, I rely most on the physical therapist to help with this because if they treat the patient, and in their evaluations, they evaluate for vestibular problems and visual ocular problems. But if they treat vestibular problems, a lot of times the visual ocular problems will resolve. If they don't, then I think about and what are the options in referring them to a neuro-optometrist. And again, the dynamic physical exertion is towards the end of treatment. If they go see a neuro-optometrist, a lot of times they will prescribe visual therapy. Moving on to post-traumatic migraine, the risk factor here is history of motion sickness, history of vestibular problems, vertigo, history of migraines, family history of migraine, and the symptoms here is a headache. And more often than not, the patient may come in and say, I got 2 different kinds of headaches. I've got one where it's just one-sided, it's pulsating, and I have another one that's just all over and it just hurts. They also may have nausea, they may have photosensitivity. Their symptoms can be aggravated by physical activity. The treatment for this, when they're not having the migrainous type headache, is increased cardiovascular activity is recommended, and that is followed in line with the exertion protocol and then the dynamic exertion protocol. Many of my friends in neurology use tricyclics and anticonvulsants in the treatment of these types of headaches if symptoms are prolonged. The cervical profile, that's the one that I mentioned, that just remember that, okay? Risk factors are involved. It's typically a whiplash type injury. They've had a previous neck or head injury or neck surgery. Usually I think of this, it can happen and it does happen with students and athletes, but more often than not, I see plenty of adults with motor vehicle accidents where they have, guess what, been rear-ended, and they have cervical problems. But anyway, the symptoms are headache, neck pain, numbness and tingling in the fingers and extremities, often no vestibular problems and no neurocognitive test problems on the impact test. The treatment for these types of problems which to me works very, very well, is seeing one of a really good physical therapist that can evaluate cervical range of motion, strength, look for ligament instability, and oftentimes soft tissue mobilization is important. Posture re-education is important. I can't tell you the numbers of times that I see in the physical therapy reports that posture of these athletes is terrible. Anyway, osteopathic manipulation and trigger point injections. There's one physician in our region that I really, really trust who will not do an osteopathic manipulation until he has really looked at x-rays, CT scans, and looks at the neck to really figure out, you know, if he can do something to help the person. And I've had one or two. I remember one little girl about 12 years old was having constant headaches, went in and saw him, and when she came back to see me, she said, well, he did what he did, and he made my headaches go away. And so, I mean, it was that immediate with what he did. Then there's the anxiety and mood profile. This is the one that I said sometimes fits the student that is obsessive compulsive, makes straight A's, and their whole life has been disrupted. Risk factor is maybe a history of mood disorder, history of anxiety. They're perfectionistic and have obsessive characteristics. The symptoms are increased anxiety, ruminative thoughts, hypervigilance, feeling overwhelmed. Symptoms are occurring during downtime when nobody else is around and they're not doing anything. The symptoms just sometimes seem to be magnified. And the new neurocognitive testing on impact may be normal. Part of that is with some of these folks, it's because they're such really, really good students. They're going to do so well on the impact test. I've had one or two come in and they scored above the 85th percentile on all 4 measures. The thing that's good to do with these folks is to have supervised exertion therapy because it can provide an emotional release for their anxiety and things like that. If they do have vestibular problems, you should treat the vestibular problems first. Again, it's very important in looking at sleep, diet, hydration, and stress and helping them to manage what is going on. Also, counseling and sometimes pharmacological interventions for anxiety and mood can also be helpful. A lot of these profiles can overlap. More often than not, they do. Typically, when the athlete student first comes in the first week, they fit every profile. It's not until probably 10 to 14 days do you really start being able to hone in on a particular profile that fits that patient. But some of the profiles that may coexist, vestibular, you know, a lot of times I see visual ocular problems along with that. There can be cognitive fatigue, post-traumatic migraine. They can have vestibular and visual ocular problems. Anxiety and mood can be associated also with migraine and vestibular problems. A person that has mainly cervical problems over time, as that is improving, they often will have problems with anxiety and their mood. So now, since Jamie wanted me to talk about this, I'm going to talk about return to school and academics. So with that, let's first look at the Virginia law in 2015 and 16, and there is return to learn is specifically in their protocol and guidelines. There is graduated phases. The goal is allowing student athletes to participate in classroom activity without their symptoms getting worse. There is 4 phases, and the phases are cognitive and physical rest, light cognitive mental activity, and then there's maximum, moderate, and minimal modifications in the classroom, and then it leads to full-time participation. If the student athlete has prolonged symptoms, say, of a month or more, it's probably appropriate to get the student and the family and the school to develop a 504 plan. The Concussion in Sport, 2016, they support academic accommodations to support students in their recovery. They do specifically say that they should not return to sport until they've successfully returned to school. And it should start with an early introduction of limited physical activity. This slide here depicts the stages from the Berlin conference. The first two stages are activities that they can do in the home without increasing their symptoms. It might include reading, starting with screen time for low periods of time and then gradually build up. Number two is still, even though it says school activities, that means school activities in the home before they go back to school. And then three is they're actually returning to school with a gradual introduction of schoolwork. May need to start with a partial day and increase breaks during the day. And then number four is full-time return. From here up, I don't take students and athletes out of school very often. The new research says the sooner you can get people back in school and get them to participate, the better they're going to do. You say, well, what do you mean? Well, there has been some cases in which probably I don't really believe that anybody should be out of school for more than 2 days, or maybe 3. Sometimes I have see a patient on Wednesday or Thursday, and okay, we got Wednesday, Thursday, and then school starts again on Monday. So I may say, okay, I want you to stay out of school 2 or 3 days, and then start school on Monday, and then I make recommendations to what I want them to do. Sometimes with people that have an extreme number of symptoms and problems with dizziness, I have sent students to school and advocated that they go to school, go to class, maybe only for a half a day, and if all they can do is go and listen, put their head on the desk, not take any tests, not do anything else, what they're doing is they're getting used to the lights and the noise of that environment. Also, it's doing something else, is that you're working towards empowering that student to go back to school, and you're not taking them out and putting them in that role for a long period of time of being a victim. So I do that. I've had problems doing that. Not me, but the schools have had problems in calling me and saying, what do you mean sending them to school? They can't do anything. And I said, well, they are. They're learning to get used to the lights, the noise, and the stimulation, and I have found that it does work. When you talk about accommodations for students, the accommodations can be as such as you want them to be and as creative as you want to be. For example, you can say no school, you can attend school for half time, no test for a grade, no exams, particularly at the end of the fall semester and the beginning and end of the spring semester. One thing that parents really like, no sports until you're caught up with work, testing in a quiet room, extra time on tests and projects. It's also helpful to have students have notes provided to them by their teachers. These are just some accommodations. There's other accommodations by McGrath in an article that he wrote. To me, the one that's here, the most important probably from what he put and talked about, is rest periods during the school day. So anyway, that sort of is getting them back into the classroom. So return to sports. Here I'm going to say that let's first talk about the Virginia law. And the Virginia law says no member of a school athletic team shall participate in an event or practice on the same day he or she was injured. They have to exhibit signs and symptoms and behaviors of a concussion and been diagnosed with a concussion. They're not to go back and ever play on the same day. And then to return to sport, they need to be attending all classes, maintaining a full academic load. They should not be having any signs or symptoms or behaviors of a concussion. And then they need to go through a return to play protocol and be asymptomatic during periods of supervised exercise and have a written note provided by a licensed health care provider according to the Virginia law. With the Berlin Conference, they recommend a graduated return to play or activity where they say light aerobic exercise, sport-specific exercise, non-contact training drills, full contact practice, and return to sport. So you got two groups that are supporting the return to play protocol. Clinical recovery to me is very important. Essentially, it is no self-reported symptoms of a concussion. Performance on neurocognitive testing on the impact test should be equal to his or her baseline levels. When that kind of criteria is met, they should go through a graduated return to play protocol under the supervision of their athletic trainer. That usually includes light, medium, and aerobic exercise. Then it's followed by sport-specific drills, and then scrimmage before they actually return to play, and usually it takes 5 to 7 days. And you say, well, what do you do with the student or the athlete who does not have an athletic trainer? So the best thing I can tell you in this is I don't believe that coaches should supervise a return to play protocol. I don't think if you can help it, an athletic director should do it. Because what do those people want? They want the kid on the field, regardless. So I have found that the people that I trust the most, because they love and they care about their son or their daughter, in most cases, that I want the parents to supervise the return to play protocol, and I give them specific guidelines on how to do it, and then they come back and see me, and then I'll write a note clearing them for sport. So what do you do with complex cases, cases that take forever to get better, a person that's had multiple concussions? Factors that I consider is age, also history of ADD and learning disability. I can't tell you how many times I've had a student come in, they have ADD, ADHD, and they're a really good athlete, and yet their grades are C's and D's. Usually after they've had 2 or 3 concussions, I just have a very frank conversation with the parents and the student, and I just say, hey, why do you want to go back and play? You know, if you might be at risk for having a problem with another concussion, and as a result, you know, it's going to disrupt your life for a couple of months. I'm not always successful, but this is after they have clinically recovered. So I usually put it back on to the parents and the athlete and say, you know, if you were my son or daughter, I wouldn't want you going back. But, hey, this is a family decision for you to make, and then we talk about it, and they make a decision. Grades and performance in school should be back to pre-concussion level. With multiple concussions, there's essentially 3 questions that I sometimes talk to students and their parents about. And I say, okay, with each additional concussion that you have, does it seem to take less biomechanical force to cause another concussion? I had an athlete come in one time, and he said, hey, when I was real young, they gave us helmets. We all got our helmets on. We got out on the field. Just so we'd know what a helmet was like, we butted heads, and it didn't bother us. And you can sit there and visually see these kids doing that. And then the next thing you know, he said, I have a concussion, and he says, phew. Then he says, then I get hit in the head again, and he said, this is like high school now, and he says, you know, it seems like every time I get hit in the head, it seems to take less force for me to have a problem or get dazed. Another question I asked, does it take longer to recover between each additional concussion? And then another one is, you know, with the occurrence of a concussion, then another one, subsequent concussions, do the concussions seem to occur more frequently? And if the student, the parents say yes to any of these questions, I say, well, you know, I think it's important to think about whether you want to move forward and play. I said, I don't have a problem clinically. If you want to go play, I'll support you. But at the same time, you know, I think it's something worth thinking about. And then, you know, there is some outliers that I see that I don't always get the student, even adults, better, and they have persisting functional problems with headaches, attention, and learning problems. And because of that, then they definitely should probably retire from the activities that cause their problems. There's a lot that we know about now in the treatment of concussions, but there's also a lot that we don't know. What I'm doing today, you know, is not anything like what I was doing six years ago or so. CTE I'm going to try to do this real quick. You can look at the slides, but I'm looking at time. And when I've done these talks before, I think it's important to give y'all any time you want. But sometimes I've done this. Okay, time to go. Nobody has any time for questions. But anyway, chronic traumatic encephalopathy is abnormal tau protein in the brain. And it can be found in people that have chronic traumatic encephalopathy. It can also be found, the abnormal tau can also be in a host of other neurological conditions. And I recently read an article that there's 20 other conditions that they can have abnormal tau. The signs and symptoms of CTE, it can only be diagnosed at autopsy. And it should never be diagnosed at this point in time in somebody that is living. The signs and symptoms can be forgetfulness, depression, irritability, and personality changes. And if these kinds of things occur, then the thing to do is to have a thorough medical evaluation, neuropsychological evaluation, psychiatric evaluation, and you put it all together and you try to treat those symptoms, because oftentimes the symptoms can be treated and the person can get better. You know, the research and what's going on out there in the world of CTE, they don't know the exact cause of CTE. There does seem to be a relationship between head trauma and CTE, but there's no cause and effect relationship. You know, at the present, there's a lot of researchers that are looking at a lot of the factors that you see in black. The other thing, I mean, and they're looking at these things to try to figure out what is happening in the world of CTE and what may be precipitating factors. The history of repeated head trauma is often found in athletes. Not all athletes with a history of repeated brain trauma develop CTE. CTE has been found even in non-athletes. So you can see by looking at the real data here that, you know, it's really mixed. There's a lot that we don't know. The media has done a terrible job at really explaining this. For example, I think it was in the past year, the media said that there was 110 people with CTE out of 111 people, and 99% of the people had CTE. And that was looking at the people out of the Boston group where Ann McKee is. And basically, you need to understand it's a very, very small sample of people. And it's people that had behavioral problems, psychological problems, and that they were earmarked as potentially having CTE before the brains got sent to the University of Boston. Anyway, there is no research that is causally linked to youth contact sports to CTE. There's no CTE in young children. There are some reports of abnormal tau in protein in deceased athletics. So from this, it's important to have effective training and management of concussions, take measures to reduce exposure of the head to traumatic forces, and then after a person has a concussion, proper management reduces the risk for prolonged symptoms. And there's some things that have been recommended for, and you can think outside the box and be creative, but measures to reduce head exposure in contact sports might be, you know, for example, no head-to-head contact, no tackling in practice, and only, for example, do that in the game. So with that, so a lot of times, in summary for about CTE, the CTE stuff in these slides are from the Neuropsychological Sports Society. It's a position paper. And then the other is from the Concussion Sport 2016, and they both really say about the same thing. In summary, with regards to CTE, I tell parents real quickly, you know, CTE is important to know about. It does exist. But, you know, it's not a causally relationship, and it does not necessarily mean that your child is going to get CTE. And that's basically how I try to summarize it to the parents when they ask about it. The references that you see here is from pretty much what I've said. There is one other thing that I do want to mention. Most of you folks here know all about psychostimulants. The one I want to mention to you is amantadine. Amantadine is relatively safe. There's a study by Reddy and colleagues in 2013. It's a very, very small sample that they used. They gave people the impact test. Then they gave 100 milligrams of amantadine in the morning and the afternoon over a 4-week period, and they retested them with impact, and the results support greater improvements from pre to post-test in symptoms, verbal memory, and reaction time. So I just want to mention that to you. Now, to take care of Janie, here's the questions. The clinical profile has the following symptoms: headache, neck pain, possible numbness in extremities, and may have no neurocognitive problem. Am I supposed to answer, or what am I supposed to do? There they are. Huh? Janie, what am I supposed to do?
You have to answer the question.
Okay, the answer is cervical profile, okay? No, I'm just, you told me to do this like before I went on vacation. All right, the next one is, you're supposed to pick the best answer for an athlete to return to a competitive game. He or she must have completed the following. Which is the best answer? The answer is D. Okay? And then the last one is young children are at risk for chronic traumatic encephalopathy if they play tackle football and had a concussion. False. So anyway, hey, I did talk about amantadine. That's where it was supposed to happen in the slides, but I've already told you. Just know, seriously, I've called pediatricians and I've asked them to please try amantadine 100 and 100, and they look at me and I sent them the journal article that I referenced here by Reddy, and they tried it and they were amazed. So, and we use it a lot in adult head injuries, so just to let you know. So anyway, sorry, we got 2 minutes.
Okay. Any questions or comments in the room?
I'm sorry.
Yeah. All right, I'll unmute the phones here really fast. We've got, I think, our largest group online we've ever had here. So if you're on our phone line, please just mute your phone if you do not have a question or want to make a comment.
The conference is now in talk mode.
Okay, does anyone on the line have a question or want to make a comment? Well, now they're scared. Okay, going once, going twice. Anybody in the room?
I'm going to hang out here for 5-10 minutes if anybody just wants to come up here.
All right, thank you very much, sir.